Hi, my name is Meg Begany, and I am a neonatal dietitian at the Children's Hospital of Philadelphia. Today's course is just one in a series of subjects brought to you by Channel 1, On-Demand Nutrition Education. Today, we are looking at infant bone health, screening and prevention of metabolic bone disease, Part 1. Our objectives today for Part 1 of this talk are to understand the risk factors related to metabolic bone disease in the infant population and to discuss strategies for the prevention and treatment of metabolic bone disease in infants. Metabolic bone disease is characterized by skeletal demineralization, and in severe cases, the bones can become so fragile that fractures of the long bones and ribs can occur simply from routine handling of the infant. Metabolic bone disease in the infant occurs mainly as a result of inadequate intake of calcium and phosphorus. These inadequacies in intake can occur in utero or after birth from deficits in the diet. The incidence of metabolic bone disease has been documented to be as high as 23% in very low birth weight infants, defined as those less than 1,500 grams birth weight, and as high as 55% in extremely low birth weight infants, or those that are less than 1,000 grams at birth. So which infants are at risk for metabolic bone disease? Metabolic bone disease can occur in both preterm and term infants who have decreased intakes and nutritional deficits. The deficiencies can be in either micronutrients or macronutrients, but of course, calcium and phosphorus are of particular importance. Because of the limitations in mineral intake that can be provided from parental nutrition, patients with prolonged exposure to parental nutrition are at high risk for metabolic bone disease. Those who are exposed to medications that are antagonistic to bone metabolism are also at risk. Unfortunately, some of the medications known to affect bone health are ones commonly used in the care of hospitalized infants. Infants with conditions such as short bowel syndrome, renal disease, and congenital GI malformations, which lead to malabsorption, nutrient losses, or decreased intake, are at risk for metabolic bone disease. Additionally, those born at birth weights less than 1,000 grams or gestational age less than 32 weeks, or with intrauterine growth restriction or placental insufficiency are also at risk for metabolic bone disease. As I mentioned, demineralization can occur in both the term and preterm infant, but I wanted to highlight the preterm infant in particular, as prematurity alone is a major risk factor for metabolic bone disease. Since all preterm infants miss some or even all of the third trimester, the preterm infant misses the portion of in utero life where bone mineralization is the highest. Approximately 80% of bone mineralization occurs during the third trimester, with peak accretion not occurring until between weeks 34 and 36 of gestation. Similar to weight-bearing exercise in the adolescent or adult, in utero mechanical stimulation from kicking or other movements against the uterine wall are thought to have bone health benefits. So that lack of mechanical stimulation due to premature birth also becomes a factor in the preterm infant. Prematurity is known to affect the balance of some hormones that have a role in bone health. The loss of placental supply of estrogen and an immature PTH response contribute to skeletal demineralization. The immature GI tract of the preterm infant can lead to feeding intolerance and the need for prolonged parental nutrition. If a preterm infant is intolerant to the feeding options that are designed to meet the specialized needs of a preterm infant, then term products are often substituted, which may lead to deficits in mineral intake. Due to immature renal function of a preterm infant, there may be substantial losses of phosphorus in the urine, even in the setting of low normal phosphorus levels. And we really struggle often in our tiniest babies who have urinary losses of phosphorus due to their immature function. Although metabolic bone disease can lead to long-term poor growth and pathologic fractures, most infants don't display any signs or symptoms until relatively late in the disease process. So the diagnosis of metabolic bone disease can be easy to overlook. Metabolic bone disease is often an incidental finding that's discovered on biochemical screening or on X-rays taken for other indications. Fractures may present as pain on handling, swelling, tenderness, and deformity at the fracture site. Typically, these fractures are in the long bones or the ribs. Changes in laboratory values or in X-ray findings typically present between 6 and 16 weeks after birth. Unfortunately, clinical sequelae such as short stature, dolichocephaly, Bone deformities because of the fractures and dental caries can extend into young adulthood. So how do we prevent and treat metabolic bone disease? Ideally, metabolic bone disease is prevented by optimizing nutrition and minimizing risk factors. Calcium and phosphorus should be optimized in both parenteral and enteral intakes. Calcium and phosphorus requirements of the preterm infant are based both on maintenance of normal laboratory concentrations, as well as matching the demands for calcium and phosphorus in order to mimic in utero accretion rates. When providing parenteral nutrition, it may be possible to maintain normal serum lab values, but it's very difficult to match the quantities of calcium and phosphorus needed to achieve fetal accretion rates through parenteral nutrition. Therefore, frequent monitoring is required when nutrition is via the parenteral route. I will discuss some of the monitoring strategies in part 2 of this talk. Because of early hypophosphatemia in extremely low birth weight infants, provision of phosphorus, even in the first bags of parenteral nutrition, may be key in optimizing intake from parenteral nutrition. When enteral products are used, it's much easier to provide adequate calcium and phosphorus intakes to the preterm infant. However, if term formula or unfortified human milk are required for the preterm infant, special attention must be paid to bone health. In infants that have risk factors, high mineral intake from feedings or supplementation should be continued until a weight of 3.5 to 4 kilos and up to 52 weeks post-menstrual age. This may require extended use of hospital-grade preterm products such as human milk fortifiers and preterm formula until the weight of 3.5 to 4 kilos is achieved in at-risk preterm infants. When fortifying feedings, the clinician must focus on nutrient content and not calories alone. Targeted additional mineral supplementation should be considered when there are signs of calcium or phosphorus deficiency. This slide shows recommended intakes of calcium, phosphorus, and vitamin D, as well as the recommended ratio of calcium to phosphorus. Additionally, the last row of the chart provides guidelines for supplementation from a 2014 publication from Rustico, Calabria, and Garber. As you can see, for parenteral intakes, the goal is 50 to 80 milligrams per kilo of calcium. For phosphorus, around 40 to 90 milligrams per kilo per day. And then the ratio that you're trying to achieve in parenteral nutrition is 1.3 to 1.7 to 1. In our smallest infants, in the first week of life especially, the ratio may be a little bit lower and then eventually transition to this goal ratio. And then vitamin D intake, the goal is 400 IUs, but it should be noted that based on parenteral nutrition IV vitamin dosing, the infant may not receive that 400 IUs until they reach a weight of 3 kilos. For enteral nutrition intakes, the goal is 120 to 220 milligrams per kilo per day of calcium, phosphorus intake 70 to 120 milligrams per kilo per day, and then the optimal ratio is closer to a 2-to-1 ratio. Vitamin D recommendations are a minimum of 400 IUs per day, with some infants requiring up to 1,000 IUs from a combination of what is provided in their feedings as well as supplementation. When supplementing an infant with additional calcium or phosphorus, the recommended starting dose for calcium is 20 milligrams per kilo per day, and for phosphorus, 10 to 20 milligrams per kilo per day. Supplementation can be advanced up to a maximum of an additional 70 to 100 milligrams per kilo per day for calcium and 40 to 50 milligrams per kilo per day for phosphorus. Some infants may require additional vitamin D supplementation, and supplementation should be guided based on laboratory values for vitamin D. In summary, metabolic bone disease is prevalent and often underrecognized in hospitalized infants. Early screening, diagnosis, and treatment is recommended to prevent short and long-term clinical sequelae. Please view part 2 to hear about screening methods for metabolic bone disease and about the use of pathways and protocols to aid in the prevention and detection of metabolic bone disease and fractures. I would encourage you to watch for upcoming Channel 1 videos on nutrition and learn more from my esteemed colleagues. Have a great day.